So the next one I went to was sickle cell pain management. Actually, we don't take care of a whole lot of sickle cell. I don't think any of us do, just kind of as a product of the places that we practice. But I think it's important to talk about because I do think there's like a number of people who both listen to the show and practice in an environment that has to take care of a lot of sickle cell. And the talk was given specifically for sickle cell pain management, not all like sickle cell care. And it's given by Nirmish Shah from Duke. I'm going to kind of highlight like three things. You know, the first that I thought was interesting is that there's a lot of stigma that goes with sickle cell. And one of the things he said is that, you know, in the patients that you would, you know, quote, label as frequent flyers or high utilizers, you know, that's really a product of them having more severe disease. And that might mean that we need to be a little bit more cognizant of the care that we're providing to them, you know, improve kind of the communication that we're using to make sure that we're really reaching like good kind of goals and plans for those patients, which I just, again, near and dear to my heart. So have to mention.
I feel like I raised you well.
I know. And the other thing that he said that I don't think about a lot, distraction therapy, especially when they first come in crisis, is actually recommended oftentimes by their outpatient sickle cell provider. And so just because you see the patient, you know, earbuds in, listening to music, trying to get up and walk around, that's could be part of their distraction therapy. It doesn't necessarily mean that they're comfortable. For someone who has been dealing with the like illness since birth, you know, really being cleared, like communicating, you know, like how does this feel different and all of that. I thought was pretty interesting and something that I haven't thought about, and something he had mentioned is something he has to like educate his like nursing staff about at times too. The last thing I'll kind of just like highlight from it is that the guidelines aren't backed by the most fantastic of studies for a variety of reasons. And so it's not like any recommendation has like the most strong of evidence along the way, which unfortunately then I think is what causes a lot of stress for the hospitalist, because, you know, you don't have like the clearest like guidelines to go off of, and it ends up meaning that you need a lot of help. So the other thing that I think is just worth mentioning here is that, you know, really he emphasized getting their outpatient provider involved early. I think we talk about this sometimes in our transitions of care parts of like our episodes, but, you know, we often think about reaching out to, you know, primary care or like whatever specialist kind of at time of discharge, but he really recommended reaching out to that specialist early, like even at time of admission, because they can really help, like, you know, they have a relationship with that patient, have probably had that relationship for a long time, and have had several conversations communicating expectations or, you know, whatever goals they had and whatever their pain like plan had been, you know, for like their next crisis. And so can actually offer you like a lot of help and guidance so you don't feel like you're starting from scratch. And so I just thought that was like really helpful to kind of make sure you're framing everything right. And I think it kind of emphasizes the need for like really good communication, which ends up being probably the most important part of like pain management. So I think it's a good segue though into kind of the last talk that you and I went to, which was pain management in the acute setting, kind of going through different scenarios with different types of patients that might be coming in with like acute pain. So patient who has an acute pain issue like pancreatitis, but may not have any other underlying chronic conditions, all the way to someone who comes in with, you know, acute on chronic pain because they have back pain, chronic back pain they have, might be on like some sort of long-term opiate and now comes in with pneumonia, and then plus opioid use disorder kind of complicating the picture as well. That was given by Dr. Park and Dr. Vatisse, also from Emory. I think that if I had to pick like one of my highlights from it, you know, they reference the open like portal or whatever you want to call it. But essentially they've taken studies that surgeons have done, kind of looking at kind of what would be optimal amounts of opiate therapy someone might need after a particular procedure. And I just think this is like so helpful, because how many times do you discharge a patient and you're like, I don't want to overprescribe you. But I don't really have a good frame of reference for like how many pills is that. I just think that's so helpful to like be able to reference something and say like, hey, for the C-section, most of the time they need somewhere between 0 and 20. I'm going to assess how much they're using now and then kind of make a best kind of taper plan with the patient in front of me.
I think it ties into your sickle cell, conversation too. Pain is so hard. I think pain is one of the hardest things to learn as any type of practitioner. And I think it's one of the hardest things to learn in residency and even going forward. And it's to your point, you never want to overdose someone, right? Like even acutely, that can obviously cause death. But even in the longer term, you don't want to send someone out on too much to put that in this. And she makes this point to put it in circulation, right, for a community. But you also don't want to underdose. You want to treat people's pain. One of my takeaways from that seems really simple, but I think that in training and then in practice, I've really gotten away of using NSAIDs. And I think it was a good reminder that even low dose NSAIDs really do provide pain relief. And depending on your patient, of course, can be used safely, even in patients with some CKD up to stage 3, or if you use, depending on the manner that you use them, or if you use them with, protonics, GI prophylaxis, you really can be used safely, particularly in an acute setting. And then hopefully you won't have to use an opioid in a particular subset of patients. And I think that was a good reminder for me because I jumped to opioids thinking, oh, I don't want to use NSAIDs. They have all these complications. It's not to minimize those, but I think evidence-wise, you can use them safely at lower doses.
Yeah. And I thought, one of the reasons I really like pain management is because the number needed to treat is actually so low to reduce like pain level. So it just feels very satisfying. So I know you were impressed by your number needed to treat of like 12, but we're talking about number needed to treat of like 1.5 to 2.
Boom.
So it's just like super satisfying.
I'm feeling very ganged up on right now.
As you should.
So yeah, like I agree. And I think like, they had like the data for like even an ibuprofen of like 200 milligrams having, the ability to have like a number needed to treat around 2, which like was to decrease, pain levels by 50% in the hospital. So it's not insignificant. I mean, if someone is like at a 8, you've kind of decreased them to a 4. So it's not like nothing. I'd be pretty satisfied with a 4, in my patient. Maybe not for myself. No, I'm just kidding. And then I think the other point that I want to highlight from that is, in your patients who come in with concomitant like opioid use disorder, who might still be, either actively using, injecting drugs, or like even if they're just buying whatever off the street, it doesn't really matter. Everything these days is contaminated with fentanyl. So like they're probably on much higher doses essentially of the opiate than we even had to deal with 5 years ago. But also just to remember, like treat them for their opioid use disorder. You will have much more like comfortable patients, not trying to like get up and leave the hospital, before they're like medically ready, and, they'll be more comfortable and be, I think, a little bit more trusting too of like the healthcare system. So just kind of framing that and making sure that we're doing that. So if that's with low dose methadone, like that can be like a great option, and not just doing like some baby tramadol.
That was the favorite part of the talk for me. I come from an area, because I'm in Appalachia, and our opiate use disorder population is unfortunately increasing. So I see a ton of that. I see so many patients who come in who, are using drugs and using opioids before they come into the hospital. And then they either have, they have some acute illness and maybe they're going through withdrawal, and they also may be in pain from whatever brought them in. And so you can't ignore, this other disease just because it's difficult or you don't like it or whatever your personal feelings are. And to your point, those patients leave against medical advice. It's safest for them to go through withdrawal and also to treat whatever pain they may have on top of that and their disease state. That's better for everyone. So I think it's a good reminder that these patients can certainly be challenging, but there are ways to tackle this, to treat them for more than just whatever acute problem they have, because there's so much else going on. And it's so important to do all of those things for them.
Yeah. And then I'll just shout out for Curbsiders Addiction Medicine. They had their series, which had like a lot of great information, kind of talking about a lot of both opioid use disorder as well as like everything else.